I think everything's all right. These are my disclosures, and the main goals for this talk are to talk about device-detected AFib in stroke patients, and I will try to show you why some people think that it's a unique type of AFib. What are the possible explanations for those differences compared to other types of AFib, and what is the role of anticoagulation in this population of patients with stroke and AF. So we've known for many years that AFib increases stroke risk by 5-fold. This is what we have been repeating for over 50 years, I think now. And we also know that if we use anticoagulants, we can reduce that risk of stroke by 65%. And this is either with vitamin K antagonist or direct oral anticoagulants. So based on that, stroke neurologists started to think that it would be very important to find AFib in stroke patients, and look for AFib as much as possible so that more strokes could be prevented. And from that concept, there were 2 landmark studies that were designed to prove that by looking more for AFib, we could find more cases of the arrhythmia. So those 2 trials were Crystal AF and Embrace. Crystal AF used implantable loop recorders, and Embrace used an external loop recorder for 30 days. Both treatments were compared to standard of care monitoring, which at that time was either an ECG or 24 hours of Holter monitoring in most of the cases. And both trials showed quite substantial, very substantially higher detection rate of AFib in patients with either implantable loop recorders or external loop recorders compared to standard of care. After that, the international guidelines started recommending using prolonged cardiac monitoring, but in a quite vague form. They were unable to specify duration or ideal duration in terms of cost effectiveness or detection yields for AFib. So most of the guidelines started suggesting more than 14 days. And that led to the real world implementation of prolonged cardiac monitoring with a really important uptake on prolonged cardiac monitors throughout the world. And that, of course, resulted in a new era in how we classify AFib. And in 2017, 3 years after those 2 landmark trials, we published this definition of atrial fibrillation detected after stroke, in which we tried to classify heart rhythm based on how it was detected. So there was a first group in which patients were detected with AFib before the stroke because they had symptoms, because they presented to the emergency department and had a 12-lead ECG. And those patients are considered to be very high risk and are the ones that we have known for many years. And this is what we called known AF or CAF. And then for those patients who did not have a history of AFib in the past and then had an ischemic stroke, those are the ones who usually have prolonged cardiac monitoring, and some of them will never develop AF, but some of them will be found to have AF, and this is a group that we called AFNET. So if we put this in numbers, we can say that approximately 20% of stroke patients in all population-based studies, observational studies, the proportion of patients with known AF is 20%. And then among the remaining 80%, if we apply implantable loop recorders, we will end up finding AFib in 24% of them, which represent 19% of the overall population of ischemic stroke patients. So we can quite confidently say that 4 every 10 patients with ischemic stroke will end up having atrial fibrillation, either detected before or after the stroke. And if we put that in numbers again, based on the number of ischemic strokes that happen around the world in a single year, we can estimate that if all of those patients received prolonged cardiac monitoring, we would be diagnosing between 1.3 to 1.5 million cases of AFAS or atrial fibrillation detected after stroke per year. But since we started investigating atrial fibrillation in patients with stroke, this goes back to 2010. When I was in Argentina, we had a telemetry system, and I was very interested in seeing which type of patients were diagnosed with AFib. And my first impression was that there were young patients without structural heart disease and without any history of heart disease either, that were diagnosed with AFib in the first 24 hours after stroke, and then they would not have any further episodes of atrial fibrillation during their admission, or they would never come with another episode of AFib to the emergency department after being discharged for the stroke. So that led to this meta-analysis that you're seeing here, in which for each of these risk factors, vascular comorbidities of structural heart disease, we did a single meta-analysis. So each of these variables is a meta-analysis in which we compared studies that compared patients with AFib detected after stroke or AFib known before stroke. And what we found is that some vascular risk factors such as hypertension and dyslipidemia were less frequent in patients with AFNET compared to known AF, 21% for hypertension, 18% for dyslipidemia. And when we looked at vascular comorbidities, we can see that there was a very substantially lower proportion of all of these comorbidities in patients with AFNET compared to CAF or known AF. And then when looking at structural heart disease, which, and I mean these two markers here are markers of high risk of stroke, we found that the left ventricular ejection fraction was 25% higher in patients with AFNET, and the left atrial size was 65% lower or smaller in patients with AFNET compared to known AF. So if we look at the overall picture, we can see very clearly that these patients are different from these ones, and that overall they have a quite benign profile compared to the other group. So by looking at the CHASPA score, we also found that it was 47% lower in patients with AFNET, and putting all that together resulted in a 26% lower risk of recurrent stroke in patients with AFNET compared to known AF, without differences in death. So what we can say here as a first conclusion is that AFNET and CAF are different. They have different risk factors. They have a lower prevalence of cardiovascular comorbidities, a lower prevalence of structural heart disease, and a lower stroke recurrence risk. And that's pretty consistent about all the observational studies. And interestingly, what those studies show is that mortality is the same for those groups. And maybe that's because mortality is driven by the stroke itself and not by the underlying cardiovascular comorbidities or AFib. So why are these types of AFib different? And there are several explanations that can be summarized in this formula here. So the AF-related embolic risk can be understood as the interaction between AFib burden, meaning that, and for burden, we define it as the duration of atrial fibrillation, the time spent in atrial fibrillation as a function of cardiac monitoring duration. The other factor that really matters is vascular risk, as you can see here in this chart that I'm going to show you in a few seconds, and then structural heart disease, including left atrial size. So here you can see that for different levels or strata of AFib duration, in this matrix with different levels or severity of the CHASPA score, the risk is much higher when the AFib burden is higher and when there are more points in the CHASPA score. So there is a clear interaction between vascular risk, structural heart disease included in the CHASPA score, and AFib burden. So it's a matter of both interacting to cause risk. So we talked about vascular risk and structural heart disease, as I showed you before. So let's focus now on AFib burden. And what do we know in terms of AFib burden regarding cardiac monitoring? We know that so if we use an ECG, we will probably see patients who have very high burden AFib. Each of these vertical blue lines are the duration of AFib throughout time. So this is 1 year before stroke onset. This is 1 year before, 1 year after stroke onset in patients who have an ECG. As you can see here, the ECG is a green line in which means the day in which it was done. Then there are patients who only develop a short burst of AFib a few days after the stroke, and if they don't have a repeat ECG, that AFib will be missed. And there's a third group of AFib patients with stroke that have just a few low burden bursts of AFib, which are not related with the timing of the stroke. So if we do an ECG there, we will miss them. So what I'm trying to say here is that only high burden AFibs are diagnosed with ECGs. So whenever you see AFib on a 12-lead ECG, it means that it's high burden and high risk, and there's no question that those patients need to be on anticoagulants. For those who have a 14-day Holter, we may find episodes of high burden. As you can see here, we may catch those brief episodes that happen after stroke, but we will certainly miss these ones here, which can be considered as bystanders and maybe not having a causal relationship with the stroke. And then if we do a 3-year implantable loop recorder or 5-year now, we will be able to find all types of atrial fibrillation. So if we look at this picture as a whole, we can see here that ECG detected AFib is high risk, and this is moderate risk, and this is very low risk, just because it is a very heterogeneous group of atrial fibrillation when we find it in a loop recorder. So we can understand this as a matrix in which there is an interaction between duration of monitoring and burden of detected AFib. Excuse me. So for a short duration of monitoring, when we find AFib, it's probably high burden. For a very long duration of monitoring, if we find AFib, it will be probably a lower burden type of AFib, and because of that, it would be a lower risk type of atrial fibrillation. The problem now is that it's very difficult to know whether the AFib that we find in loop recorders, in implantable loop recorders, is high risk or low risk, and this is something that I'm going to talk in a few minutes about. So going back to this picture in which we talk about the risk of stroke associated with AFib, the important part that we need to understand is that all that information came from these observational studies from Framingham in 1978, 1991, in which we first realized that AFib was a risk factor for stroke. After this paper, there were a few randomized controlled trials in which it was shown that warfarin was able to reduce stroke risk by a significant proportion. So what these studies have in common in general is that they are based on ECG detected AFib. So these are studies that were done in patients with very high risk of AF in a historical moment in which patients did have a lot of strokes when they had AFib because of the poor control of other risk factors. So going back, these are ECG detected AFibs. But now we're dealing with patients with 14 days, 7 days, or 30 days of Holter, or even 3 to 5 years of implantable loop recorders. And when we look at data from implantable loop recorders, we can see that if we can measure episodes of AFib lasting less than 30 seconds, more than half of them last less than 30 seconds, and the other half last more than 30 seconds. So it is very, very common to see very short-lasting episodes of AFib. If they last less than 30 seconds, they're not even classified as AFib, and that's based on a definition made by consensus by some European experts about 30 years ago. But it doesn't really have a clear rationale now. So this is just to show you that very short-lasting episodes of AFib are extremely common in patients with stroke, but we usually ignore them because they last less than 30 seconds. And going back to the other scheme, when looking at the results of studies of implantable recorders applied before stroke onset and kept after stroke onset, we can see that there are basically three patterns of AFib in stroke patients. There are episodes of very high burden of AFib that is pre-existing before the stroke, but we usually don't know this because our patients are not wearing the implantable recorders before the stroke. We just know this from some research studies. There are some patients in whom we find a very high burden of AFib, and that's new after the stroke. So there seems to be a trigger for that. Stroke may trigger some arrhythmogenic mechanisms here in patients who are susceptible to developing AFib. Then we have some remote low burden episodes that are probably bystanders and happen quite after stroke onset, and they may not happen again, or they are very infrequent. So what we think about these episodes is that it might be the very early onset of an AFib that will become more evident maybe 5 or 10 years later, or it might be just even a normal physiological phenomenon for some people to have very short-lasting episodes of AFib that happen randomly or may be triggered by other factors. And then there was a third group that we identified, which happens only after the stroke, very short-lasting burst of AFib, and then it never happens again. 20% of the patients in these studies had this type of AFib, and we think that this is really the type of neurogenic AFib that I was seeing in Argentinian stroke patients who were receiving telemetry. These were very young patients with no structural heart disease, with almost no vascular risk factors, and we really think that this is related to these autonomic mechanisms and maybe inflammation triggered by the stroke. So to kind of test that hypothesis, we developed this study in which we retrospectively investigated 336 patients with ischemic stroke or TIA who did not have known AF before the stroke. And then we compared device-detected AFib, meaning that these patients were diagnosed with AFib on 14-day Holters. And these patients here, the other group, was composed of patients with ECG-detected AFib when they arrived to the emergency department. A few years ago, we suggested that patients with ECG-detected AFib should not be called AFDAS, and the main reason is that these are AFibs that are actually very high risk, and they were very likely pre-existing before the stroke. So, but they were not detected because they were asymptomatic. So what the primary outcome of the study was recurrent ischemic stroke. So we did a Cox regression analysis to compare the risk of stroke in patients with device-detected AFib or ECG-detected AFib. And the hypothesis was that this group here, the AFib detected, the device-detected AFib, would have a much lower risk of stroke recurrence than ECG-detected AFib because it is a low burden and pretty benign type of atrial fibrillation. So this is a result. In the regression analysis, we found a 5-fold higher risk of recurrent stroke in patients with ECG-detected AFib compared to those who had AFib detected on 14-day Holters. To have an idea, there were only 2 events in 148 patients followed up to 30 months, but in a median of 17 months, and 80% of patients in this group and this group were on anticoagulants. 82-83% was the actual proportion. So, and these results are adjusted for all variables that are known to increase stroke risk. So basically what we are showing here is that, again, whenever you find AFib on an ECG, that's very high risk. What we don't know exactly is what happens with these patients in the longer time. In the very short time, this type of AFib, prolonged cardiac monitoring detected AFib, seems to be pretty low risk and quite benign. So to further assess this by including another group, we compared patients with known AF patients with ECG-detected AFib, and patients with prolonged cardiac monitoring detected AFib for a longer follow-up period. And we found, as you can see here, that that recurrent ischemic stroke was not different when comparing non-AF with ECG-detected AFib, as you can see there. So there was a higher difference here, a larger difference at 1 year. But then with time, the ECG-detected AFib almost became the same risk as non-AF. This is a Kaplan-Meier curve. When we use a cumulative incidence function curve, both curves were exactly the same. The one for non-AF and ECG-detected AFib, but I'm not showing them here. So the other issue is that the risk of stroke of prolonged cardiac monitoring detected AFib remained pretty stable after the first 12 months, meaning that it seems to be a very low risk type of AFib that doesn't progress in terms of risk. But we can see here, going back to ECG-detected AFib, that the risk of stroke was time varying. As you can see here, it was the difference between ECG AFib and non-AF was significant in the first 12 months, but then after that it became not different. There were no differences between groups, which again suggests that is a type of AFib that tends to progress, and the only reason why it was not diagnosed before the stroke is that it was asymptomatic. So based on those findings, we this year we published this paper in the European Heart Journal, in which we kind of put together a short article suggesting that the risk of stroke related or the risk of AFib related stroke varies depending on how it is detected, and it increases or it goes down with longer duration of monitoring, as you can see here. So the main concept is that again, if we find AFib in a very long duration of monitoring, it is very important to measure the burden, because otherwise we won't know what kind of AFib that is. And in general, when we use implantable recorders, the group of AFibs that we detect are very, very heterogeneous, and we might be using anticoagulants for patients that do not really need them. So the conclusion number 2 is that AFib-related risk of stroke varies in relation to the duration of cardiac monitoring, and we need to keep this in mind when analyzing the results of the clinical trials that I'm going to show you in a few minutes. So based on those first 2 conclusions that I have just shown you, we wrote this position statement paper in the Lancet Neurology, in which we suggested that we need to have a more homogeneous kind of definitions for different types of AFibs. As you can see here, the definition of atrial fibrillation detected after stroke should comprise the following criteria, including AFib or A-flutter detected in patients with stroke, or TIA, with no history of AFib, with no AFib on an ECG done after the stroke, and with atrial fibrillation detected either on short-term monitoring defined as 24 hours to 48-hour Holter, or prolonged cardiac monitoring, meaning that the duration of monitoring is higher than 7 days. We proposed some harmonization criteria for doing research in the field, and as a third conclusion, I would like to reinforce the concept that AFib detected on an ECG after a stroke is a high-risk AFib and should not be considered AFNET, because AFNET is only the AFib that we detect on cardiac monitoring. So what is the risk of stroke in these patients? So let's measure that. So we did another meta-analysis in which we looked at clinical trials only, in which prolonged cardiac monitoring was compared against standard of care monitoring, and we found that there was an increase in the use of anticoagulants, but that increase in anticoagulants did not result in a lower stroke recurrence rate. And you can see all the outcomes that were investigated in the meta-analysis, the number of studies included, numbers of patients per month of follow-up, and all the results show no significant differences. You will see a lot of meta-analysis tackling the same question, but something that that those meta-analyses did not consider was the follow-up. And since Afib is a progressive disease and it's a time-varying condition, it is very important to compare incidence rates in relation to duration of follow-up instead of just comparing proportion of recurrences. If we compare proportion of recurrences, we're ignoring a very important part of the associated risk of stroke in patients with Afib. So that's just a technical aspect that we need to consider when looking at other meta-analyses tackling the same question. So one caveat that I would like to mention here is that none of these trials aimed to evaluate stroke recurrence rates. They were designed to answer the question whether prolonged cardiac monitoring could detect more Afib, but not if it could reduce stroke recurrence. So none of these trials were powered enough to detect differences in stroke recurrence. So even if we put them together, because all of them were unpowered, and this is a study level meta-analysis, it is not surprising that we didn't find any differences. So that's something that we really need to keep in mind. But let's go to the clinical trials and try to understand whether using anticoagulants in patients with prolonged cardiac monitoring detected Afib results in lower stroke recurrence rates. So the first of those trials is NOAH-AFNET 6, in which patients without history of Afib were random and with device-detected Afib, meaning that they got implantable loop recorders or cardioverter defibrillators or pacemakers, and they were found to have atrial high rate episodes, which is a synonym of SCAF or subclinical Afib. If those episodes lasted more than 6 minutes and patients had more than one additional risk factor and were 65 years old or older, they were randomized to edoxaban or double dummy placebo, meaning that they would receive aspirin if they had any condition that would require it, for example, coronary artery disease, or they would receive placebo if they didn't have an indication for aspirin. Overall, 50% of the control group received aspirin, the other 50% received placebo. So what we can see here is there were no differences in the primary efficacy outcome, but we need to know, of course, that the study was stopped prematurely because of safety concerns related to increased risk of major bleeding or death from any cause in patients receiving edoxaban compared to placebo or aspirin. So there was a 31% significant increase of bleeding during an interim analysis, and that's why the study was stopped. And that might be one of the reasons why the primary outcome was not significant, and that is because there were not enough patients and events to show any differences. The other reason why it might not have been significant is that the primary outcome was stroke, systemic embolism, and death from cardiovascular causes. And we know that anticoagulants do not have a very strong effect on death from cardiovascular causes, so this may have diluted the effect of edoxaban compared to aspirin in the primary outcome. So the other study, the other big study of 2023 was ARTESIA, in which they used a very similar population. They included only patients with Afibs lasting between 6 minutes and 24 hours. If they lasted more than 24 hours, they would not be included. And if they found an Afib, for example, lasting 2 hours and then it progressed to more than 24 hours per day, those patients were censored and switched to apixaban, because we know that an Afib lasting more than 24 hours is very high risk. So overall, in terms of the primary outcome, it was significant in favor of apixaban compared to aspirin, with a 37% reduction in stroke or systemic embolism risk. As you can see here, there is no death as part of the primary outcome, and that might be one of the other reasons showing why these studies were different, even though they were pretty similar. Here, it was a very similar design, but all the patients received aspirin instead of placebo. So in terms of of bleeding risk, if we look at the intention to treat analysis, the risk of major bleeding was 36% higher in patients receiving apixaban compared to aspirin. But if we look at the on-treatment analysis, meaning that these patients did receive apixaban or did receive aspirin, there was an 80% increased risk of major bleeding in patients receiving apixaban. So here you can see the curves for the primary outcome. If you look at the whole picture, you can see a very, very low number of events in both groups, but still there was a 37% relative risk reduction, not absolute risk reduction. So let's put these results in perspective. This will be published soon. It's now accepted for publication. But let's review. Let's start on this side. Here we can see patients from the ESUS trials. These are patients without Afib who received either aspirin or DOAC. And you can see very clearly that this population of patients has a very high annual risk of stroke, between 4% and almost 6%, regardless of what they receive, right? So these are very, very high risk patients. Then if we look at the DOAC trials, in which they included patients with Afib, mostly detected on 12 lead ECGs, we can see that that the annual risk of stroke is around 1 to 1.4% in both groups, with very very low absolute differences. But then if we analyze patients who had a prior stroke or TIA, these are much higher risk patients. This is one of the most interesting ones, which is Averroes, patients again with mostly 12 lead ECG detected Afib. You can see here that for the overall population with and without stroke, those who received apixaban had a 3 times lower risk of stroke compared to those who received aspirin. And then if you see here patients, if you look here, those who had a prior stroke, the difference was even higher. And I want to remind you again that these were 12 lead ECG detected Afibs in most of the cases, and only a low proportion of implantable recorder detected Afibs. And then if we analyze the results of major bleeding in these two populations, we can see again that in patients with Afib, there is a very high risk of bleeding in both populations, but it doesn't happen in patients with ESUS. So let's focus on NOAH-AF and ARTESIA. Here, you can see that the risk of stroke is really very low. It's at 1.0% per year. And just as a reminder, if you look at the American Heart Association guidelines, what they very clearly state is that a patient needs to have more than 2.0% annual risk of stroke to justify the use of anticoagulants. And this is based on Markov models, and you can estimate that 2% per year, it's a CHASPA score of 2 or higher. So here we can see very clearly that in both NOAH-AF and ARTESIA, the annual risk of stroke of those patients with subclinical Afib was really, really low. There were no significant differences here. There was a 37% relative risk reduction, but only 0.4% per year reduction in terms of stroke recurrence. And then in terms of bleeding, there is a cost that we are paying for preventing those few strokes, and as you can see very clearly here, with twice the risk of bleeding in patients receiving apixaban or edoxaban compared to aspirin or placebo. And this shows that this is ECG detected Afib, and this is implantable loop recorder or other devices detected Afib. So you can see very clearly that these are very different populations, and this one has a much lower risk of stroke. So there was a small proportion of patients in NOAH-AFNET 6 and ARTESIA who had a prior stroke or TIA, 10%, 9%. And what I'm going to show you now is the results of ARTESIA comparing patients with a previous stroke or TIA and patients without a previous stroke or TIA This was very generously, these slides were very generously given to me by Dr. Ashkan Shomenesh. He presented these results at the European Stroke Organization conference last week. So here we can see in patients without a prior stroke or TIA, there was very marginally significant differences in terms of risk reduction with an estimated number needed to treat of 91. And then by looking at patients with a prior stroke or TIA, and this could have been a remote TIA or stroke. We don't know exactly the time between the stroke onset and the time of the analysis or inclusion in the trial. And there is a 60% reduction, which was significant, with an absolute risk reduction of 6.2%. Again, this is at the end of the study. We cannot compare this number with the ones that I showed you here because these are annualized rates, but this is at the end of the study. So we don't know exactly what the annual risk of stroke is for these patients. We would have to calculate it. So if we look at other outcomes, we can see that for overall stroke, patients with prior stroke or TIAs had a lower risk and there was a significant interaction. The same for just ischemic stroke or a stroke of unknown source, as you can see here. And then for disabling or fatal stroke, which is an important outcome, you can see here 6.9% rate in patients with aspirin. Again, this is not per year, this is total. And here 1.7% in patients with apixaban. And again, a significant interaction, meaning that, of course, those patients who have a higher risk of stroke would benefit more with anticoagulants than the ones that do not have such a higher risk. And then another important finding of ARTESIA is that there was no interaction for major bleeding, as you can see here. And this is different from the other risk of stroke. So the conclusions in Ashkan's presentation was that patients with device-detected subclinical Afib and history of previous stroke or TIA are at substantially higher risk of stroke or systemic embolism, and I agree with that. You can see here that rates are higher in this population, 10.3% compared to 3.6%. That the absolute risk reduction in stroke and systemic embolism with apixaban is nearly twice and increases with major bleeding. That apixaban is associated with a 74% relative risk reduction in disabling or fatal stroke. But I think most importantly, it's associated with a 6.2% absolute risk reduction. And then the last conclusion is that apixaban is recommended for secondary prevention in these patients. And I kind of agree with this. If we take the one fits all approach, and that's my fourth conclusion here, patients with AFTAs should receive anticoagulants. This is based on evidence from ARTESIA and based on the lack of evidence that if we don't use anticoagulants, these patients will be safe. So for now, everyone needs to receive anticoagulants, but ideally, in a more sophisticated approach, we should be able to personalize or make more tailored kind of decisions in these populations, or this population based on the detection method, the comorbidities, and a personal estimate of bleeding risk and patients' preferences. And going back to that, we know from the LOOP study that Afib is a progressive disease. This is when Afib is detected. The circles are at the end of the follow-up for those patients, and we can see that there is a clear trend towards progression in terms of daily Afib burden. But we can find three very clear groups here. There's a group that definitely progresses over the 24-hour mark, meaning that these patients will become very high risk. Then there's a 62% of patients that progress, but not enough to reach the 24-hour threshold. And then there's a 22% of patients that never progress. They have just one episode and it remains like that, and there's no further Afib. So this is just to show that even though in general Afib is a progressive disease, there are some patients that do not progress enough to be very high risk. So the overall concept is that throughout the years, as we age, we will start to increase our biomarker levels, such as ANP or troponin, which are associated with higher stroke risk. The Afib burden that you can see here in purple will tend to increase throughout the years because Afib is a progressive disease in most of the cases. We will start incorporating more risk factors as we age as well. We will get older, which is also a risk factor for stroke, and our left atrial size will develop more and more fibrosis and will increase in size, meaning that we will be at higher risk of stroke. So the rate at which each of us progresses varies. It's not the same based on our lifestyle and other genetic factors. But overall, it would be great if we could measure this with what we call the bad risk AFNET approach, in which ideally we should be able to monitor all those risk factors and determine when someone is at a much higher risk of stroke than in the past. So something that it's really intriguing to me is that if you see patients with myocardial infarction, you can always kind of predict when they're going to have a heart attack, because they could happen under a very intense or a very stressful situation, or if they exercise in a very cold temperature, or in situations like that. But we can never predict exactly when someone will have an ischemic stroke, despite their risk factors. So in the future, we might be able to use loop recorders or external devices or wearable devices in which we would be able, thanks to which we would be able to detect Afib and measure Afib burden. We could measure sleep quality. We can measure medication compliance, which is one of the most frequent causes of breakthrough strokes in patients on anticoagulants. We can measure real-time risk factors such as blood pressure, glucose, or lipids. Something very important is that we could detect when we are at imminent risk of stroke because of fever, excessive alcohol intake, myocardial injury, stress levels, or dehydration. And we call this dynamic risk stratification, which you may think it's kind of a kind of delirious or a crazy idea, but we're thinking of building houses and sending humans to live in Mars or even the moon. And I don't think this is impossible. There are many devices that are doing this now. There are students at schools that are working on projects like this. And I really believe that in the future, just by using a wearable device, we will be much closer to predicting when someone will have a stroke, and then have a more dynamic and effective approach to preventing strokes in patients with atrial fibrillation. So in conclusion, I think we need to move from the initial excitement that we had in 2014 or 15, and now with some clinical trials that one size fits all, and we should move to a more exactness approach, and we should select the right patients, and hopefully in the future we'll get that personalized approach, which will help us do a better and more sophisticated kind of medicine. So thank you very much. I'm going to stop here, and would be very happy to discuss with you.
Thank you, Luciano. This is fantastic. Are there, I think we should open this up. If anybody has questions for Luciano? I think Mahari has a question.
Nice to see you, Mahari.
Mahari, if you can hear us, might be having some, or maybe he
just said hi.
Oh, it's just to say hi. Okay.
I don't know. It looks like he's trying to say something, but I don't know.
He may be having some technical. Yeah. He's unmuted. Let's see. All right. Well, he says his mic's not working. Well, Mahari, you can put if you want to type your question in the chat, we'll read it out for you. In the meanwhile, I see Lauren Fournier has a question.
Yes, thank you so much for the wonderful lecture. I have a question that's not, well, kind of off topic, but what are you doing for your patients who, who have recurrent stroke with AFib on DOAC, and they're compliant and they're doing everything right? I'm just wondering what other people are doing for these patients, because I have to take care of one at 1 p.m. So I'm wondering also what is everybody doing?
Excellent. So I can talk about my very schematic approach for this. So if we look at the causes of breakthrough strokes, what you are describing is what we call a breakthrough stroke on anticoagulants. We can broadly divide the causes into two groups. One of them is because there is another cause. There is carotid stenosis or small vessel disease or aortic atheroma. So those are conditions that would not benefit from anticoagulants and could cause strokes in patients with AFib on DOACs. So first of all, we need to rule out other causes of stroke. And then the other group is AFib related. And for those who have AFib related strokes, the first question is whether they are compliant. We know that approximately 50% of patients on DOACs are non-compliant throughout the years at 1 or 2 years. So that's number one question. Number two is whether they are on the right dose. There is a lot of dosing in these patients. For example, the low dose of apixaban in patients who don't need it. So that's a question that we always need to ask. And then there are really, truly AFib related causes, and those are basically the anatomy of the left atrial appendage. 90% of ischemic stroke patients with AFib have a thrombus in the left atrial appendage. And by doing CTs of the hearts of patients with AFib, we can see that the apex of the left atrial appendage has, when we use contrast, doesn't get the contrast. And if we do it 5 or 10 seconds later, we see the contrast accumulated in the apex of the left atrial appendage, which means that the left atrial appendage has slow flow. And that might be one of the causes of DOAC resistance. What we don't know if it really works is to switch the DOAC. Data from observational studies, mainly from Bern, Switzerland, show that there's no difference. There doesn't seem to be a difference in terms of using vitamin K antagonists, but there is an ongoing proposal for a clinical trial to look at that question. So what I do is just follow that pathway, and then if I see that the left atrial appendage shows slow flow, there is no thrombus but slow flow, and patients are compliant, and there is no other competing cause, in that case I may decide switching to left atrial appendage occluder. But that needs to be proven in a clinical trial. This is just an empirical approach. We don't have proof that that approach works, but it's more based on the pathophysiology.
Excellent. Thank you. There's some questions that have come through the chat. So there's a question about timing of DOACs in AFib. I guess since we've had some new clinical trials that have come out, we wonder if you could comment on that, about the timing of starting DOACs in patients with AFib-associated stroke, late versus early.
Yeah, I think the strongest evidence comes from the ELAN trial, in which there's another study from Switzerland in which they divided patients into high or large strokes, moderate strokes, or small strokes based on the imaging patterns. It's quite kind of complex how they separated them, but basically what they found is that starting anticoagulants earlier is not associated with a higher risk of hemorrhage. So we're tending to use anticoagulants as soon as possible, and with more and more trials, it likely shows that it's not such a high risk of bleeding. For the strokes that I would be very careful is those that involve the posterior circulation, the cerebellum, that look embolic with hemorrhagic transformation. Just based on empirical evidence, those are the ones that usually tend to bleed, and if they bleed, they're quite catastrophic.
And Luciano, if there's evidence for hemorrhagic transformation in the cerebral hemisphere ischemic strokes, does that alter your thoughts on when you might start anticoagulation?
Personally, even though we have evidence from small trials like timing, ELAN, etc., I tend to wait a little bit more and be sure that it disappears. I remember a colleague from Boston telling me from the old times in which they used heparin in acute stroke that they were not concerned at all about hemorrhagic transformation, like that HT1 and HT2 for the Heidelberg classification. So those are very low risk, but still we wait 1 or more days, we repeat the CT, and when we restart them. But I know that people from Europe sometimes are a little bit more aggressive, and they don't even wait for a repeat CT, and they just anticoagulate them based on the timing.
Got it. Some more questions. Let's see here. Do you notice recurrent risk of recurrent stroke with perioperative AFib? So this concept of seeing perioperative AFib, is really interesting. Yeah.
So there are some facts and there are some unknowns. The fact is that patients who develop AFib post surgery or any type of surgery, mostly cardiovascular surgery, are at much higher risk of stroke than those who do not develop AFib after surgery. There's no question about that. What we don't know for sure is that using anticoagulants can reduce that risk. So, and we don't know because they're not well-conducted clinical trials. So it's not that the evidence shows that it doesn't work. There's no evidence. So in my view, and that's a discussion that I always have with the cardiologists and cardiovascular surgeons, is that I tend to use anticoagulants for a long time, and probably forever in those patients who have AFib or postoperative AFib. But that's, again, empirical based on the high risk that those patients show.
Another one, so Omahari was able to, at least he was able to put his question, he's talking about how to do exactness and management. Is there a suggestion when to perhaps stop anticoagulation after a period of time when patients would not likely have recurrence, especially for these lower risk patients?
Yeah, so I don't have a question for that. I think the only way of knowing is by, sorry, I don't have an answer for that. The only way of knowing is by constantly monitoring their heart rhythm, right? And that we can do it for 5 years, but we will never implant someone else with another loop recorder. We can use an Apple Watch to do that. But it's very difficult to predict who's going to have high burden AFib and who's not going to have, because it varies really a lot across people. So I don't have an answer. We will have to have those devices, or maybe they'll never exist. But I'm pretty sure at some point everything will be monitored, and we will have our own personalized approach by using AI, right? Integrated AI into those devices, monitoring everything.
Okay, another one is one from Ali Caro, one of our great former stroke fellows. Do you adjust DOAC dosing when these patients are on certain seizure medications, or in those that have duodenal surgery or bariatric surgeries?
Yeah, we don't do that a lot, but we do a couple of things. The first one is that there are some European Heart Rhythm Society practical management guidelines published in the European Heart Journal. So you have a very nice guidance there on how to adjust doses for different anti-epileptic drugs. And then there is another guideline from Thrombosis Canada that we use frequently for those cases. And in case of doubt, what we do, again, empirically, not based on evidence, is measuring DOAC levels. So we have an anticoagulation clinic. We send them we mostly use apixaban, so we send them for apixaban levels measurement. And if those levels are within the range found in the Aristotle trial, we stay with that dose. If it's lower or higher, we adjust the dose. But only those patients with severe renal function impairment or those who are on drugs that can affect DOAC's metabolism.
So then here's one about, this is also something I was hoping to ask about. So with regard, a lot of us are definitely increasing our monitoring of the patients, putting in LINQS, and it really becomes this question of, so if this is a low-risk patient and we detect AFib, will the clinical practice of the guidelines here on long-term monitoring of, like for instance, in cryptogenic stroke that appears embolic, where a lot of us are stuck about what to do, how long we monitor them for, if we do actually pick up random AFib for a couple of episodes, what do we do about this? Is the big question.
Yeah, so the easiest and most straightforward answer is, if you find AFib that lasts more than 6 minutes, everyone needs to be on anticoagulants. The best duration of monitoring, we don't have an answer for. In the past, we don't have loop recorders here because they're not covered by the universal healthcare system, but we have 14-day Holters. So we do 1, 2, 3, 4 Holters lasting 14 days each in some patients, but now I'm tending to use them 1 or twice, because if I didn't find AFib in 30 days, it means that it's pretty low burden and probably low risk. So I stopped there. I stopped with 30 days of monitoring. But if you have loop recorders, then I would be sure that you are very well connected with your cardiologist, the one who reads the reports, and then you can monitor AFib burden in those cases. Otherwise, it doesn't make sense. It might be easier to use a 14-day Holter.
Yeah, thank you. It's an evolving and dynamic issue for us all, because we have the opportunity to put in these recorders, but you know, and then the question comes up, well, how long do we keep them in for? And then when we do eventually pick up an event, what do we do with that information, particularly if it's less than that time frame of 6 minutes?
Yeah, exactly. And Sean, something important is the FIND-AF2 trial, because the FIND-AF2 trial is a German study. They have already enrolled 5,000 patients. They're almost done, and they just need to follow up on them for a year. So it will be probably published in 2025 or 2026. So that's a really smart study in which they were ahead of the field for a few years, and what they did is what they planned was a stratification of risk for monitoring. So they used loop recorders for high risk patients. They used only 14-day Holters for low risk patients, and they used anticoagulants whenever they found AFib. So that might be an approach to use in the future in a more personalized way than we are doing now. We'll see what the results show.
Oh, that's excellent. Because there was actually a question in the chat about, will there be any upcoming trials about more of what you're getting at the future about personalized, treatments for anticoagulation, particularly in these lower risk on these prolonged cardiac monitoring.
I think FIND-AF2 is a trial. We had another trial called Stargate that was just about to start before ARTESIA was presented in November last year, and because of ARTESIA, we had to cancel it before getting started, because that was the exact same population that we planned to include.
All right, I'm gonna one more question from our great colleague Yazan Aldarazi, who's asking a tough one here, from the land of abundant loop recorders. So patients with non-specific, let's call them transient neurological events that get labeled as TIA, some people call these soft TIAs, who have device-detected AFib. Do you manage like AFDAS or asymptomatic AFib, or is this about judgment modified by burden and risk factors?
Well, that's a tough one. I really don't have an answer. I know from some studies that whenever someone is sent to a neurologist or referred to a neurologist with a TIA-like episode, there is a higher risk of stroke recurrence in that population, just based on the fact that a TIA was suspected. Those are higher risk patients than the general population. I would just do a CHASMA score for those patients, and if the AFib lasted more than 6 minutes and they had a CHASMA score of 2 or more, I would just treat them. But again, I don't have evidence to support it.
Yasin, anything you want to add to that?
Me or
no, Yasin was
okay.
he appeared, so I thought maybe he had anything else to say. But he's a great. Okay, I think we will stop here. This has been really wonderful. We thank you so much. There'll be evaluations for everybody in the audience that is asking. For those that want their credit, they will get it. Thank you again. It was really fantastic.
Excellent, Sean. Thanks so much. It was my pleasure, and I really like the interaction with all the people. Thank you so much.
Take care.
Bye-bye. Have a good day.